All right, let's dive right into this comprehensive, step-by-step explainer on the wildly complex world of immunologic diseases. We're going to build your foundation from healthy immune function all the way up to some really severe systemic malfunctions. And since this is designed to be your ultimate study guide, I'm absolutely not going to gloss over the details. We're going to examine every single concept, term, and process so you can fully grasp both the how and the why behind these conditions. So let's get into it. Here's our roadmap for today. We've got 5 parts: immune system foundations, immunodeficiency disorders, autoimmune and connective tissues, inflammatory joint diseases, and finally, neuromuscular and blood disorders. Starting off with Section 1, Immune System Foundations. Let's look at the binary foundation of our immune system. Lymphocytes develop in primary lymphoid tissue, and they basically have to achieve what's called immunocompetence. Think of it as passing a strict test to prove they function properly. T cells, which develop in the thymus, are your cell-mediated attackers. This means they engage in direct, hand-to-hand combat with infected cells to coordinate the fight. B cells, on the other hand, develop in the bone marrow. They manage humoral immunity, acting like tiny factories pumping out antibodies right into your bodily fluids. And here's a crazy fact: if they fail their antigen test before being released, they are literally destroyed just to protect your body. So, what exactly is an antigen? Well, an antigen is basically a marker on a cell's surface. When a foreign antigen enters the body, it acts like a biological key that fits perfectly into your antibody's lock. This exact trigger is what tells your body, hey, an invasion has occurred. Your B cells produce different types of these antibodies to bind to specific threats. For example, you've got IgG, which is super important because it can actually cross the placenta, or IgA, which is directly linked to allergic responses. And once that lock and key fit together perfectly, it sets off what we call the complement cascade. This is a truly fascinating, multi-stage inflammatory response. When antibodies bind to a pathogen, they form a membrane attack complex. This mechanism literally blows up invading bacteria. It changes the cellular pressure, forcing water to diffuse into the bacteria until it physically ruptures. It is wild. Moving right along to Section 2, Immunodeficiency Disorders. Now, the crucial point to understand here is that genetic or acquired defects in specific cells create very distinct clinical syndromes. Let's break this down step by step for your exams. Common variable immunodeficiency, or CVID, involves a B cell drop that usually pops up in 18 to 25-year-olds, leading to swollen lymphoid tissues. Then you have selective IgA deficiency, which often presents as recurrent ear, sinus, or pneumonia infections simply because the body fails to produce IgA. Next up is X-linked A-gamma globulinemia, which only affects males and is marked by physically absent tonsils and adenoids. Then there's DiGeorge anomaly. This is a congenital defect of the pharyngeal pouches. Those are the early embryonic structures that develop into the thymus and other neck and face structures. This specific defect results in a missing thymus, along with accompanying heart and parathyroid issues. Finally, we have Wiskott-Aldrich syndrome. This one involves bleeding and low platelets, and it often requires the surgical removal of the spleen, a splenectomy, just to stop the excessive recycling of blood cells. Acquired immunodeficiencies are equally complex. When the HIV virus specifically targets and destroys T helper cells, the body becomes incredibly vulnerable to opportunistic infections. We're talking about conditions like Kaposi sarcoma, which causes these purple vascular patches on the skin, or a severe lung infection called pneumocystis pneumonia, and even fungal infections like thrush. Because HIV is an RNA-based virus, it mutates ridiculously fast. So to prevent the virus from quickly developing resistance, we aggressively treat it using a 3-drug combination called HART. This inhibits viral replication from multiple angles and protects those precious remaining T cells. All right, on to Section 3, autoimmune and connective tissues. Systemic lupus erythematosus, commonly known as SLE or lupus, is a widespread autoimmune disease. What's absolutely crucial to grasp here is the formation of immune complexes. Think of these as antibodies binding to antigens in a chained, tangled clump. These bizarre complexes deposit directly into joints, causing painful but reversible subluxations, which are partial dislocations of the joints, usually in the hands. But most dangerously, they deposit into vital organs. In SLE, closely monitoring the kidneys for protein in the urine is an absolute necessity because kidney failure is often the primary cause of fatality in these patients. Diagnosis relies heavily on detecting anti-nuclear antibodies, or ANA, in the blood, right alongside that classic photoreactive butterfly rash you'll see across the patient's face. Next, let's talk about scleroderma, a disease where the immune system attacks collagen, causing widespread hardening of the body's tissues. For your studies, you need to burn this acronym into your memory: CREST. CREST syndrome outlines the severe, multi-system hardening of tissues. C is for calcinosis, which means calcium deposits forming under the skin. R is for Raynaud's phenomenon, where the body dangerously loses blood flow to the extremities when exposed to the cold. E stands for esophageal hardening, leading to severe acid reflux and potentially precancerous tissue changes. S is for sclerodactyly, which is characterized by painfully taut skin stretched over the fingers. And finally, T is for telangiectasia, which is the appearance of spider veins. Now, these connective tissue conditions can sometimes overlap in what's known as mixed connective tissue disease, but the absolute key distinction between them is their target. As we just saw, scleroderma targets collagen, resulting in that skin hardening. Sjogren's syndrome, on the other hand, directs its assault on your moisture-secreting glands. This causes profound dryness in the eyes and mouth, which can severely impact a person's ability to chew and swallow. To test for Sjogren's, we use the Schirmer test. It uses a special little paper strip with dye to directly measure a patient's tear production. Let's shift gears to Section 4, inflammatory joint diseases. Unlike general joint wear and tear from aging, this pathway clearly shows how rheumatoid arthritis is an active, aggressive autoimmune assault. The immune system mistakenly targets the synovial membrane lining the joint. This intense inflammation creates an abnormal tissue growth called a pannus, and this pannus literally erodes the underlying bone. In severe cases, the body's response is to grow new bone until the joint fuses entirely, a process called ankylosis. And pay attention to this detail. Because synovial membranes also line certain spinal joints, RA can actually cause fatal instability in your upper cervical spine by degrading the exact ligaments holding your topmost vertebrae in place. This breakdown of the 4 primary inflammatory arthropathies really highlights how joint destruction is often systematically linked to other bodily conditions. We just covered rheumatoid arthritis. Then you have psoriatic arthritis, which occurs in a subset of patients who already have psoriasis. That's a condition creating rough, scaly plaques on the extensor surfaces, meaning the outside of your elbows and the front of your knees. Next is ankylosing spondylitis, which primarily targets and fuses the spine. And lastly, enteropathic arthritis, which is joint inflammation specifically linked to inflammatory bowel diseases like Crohn's or ulcerative colitis. When it comes to diagnosing ankylosing spondylitis, the clinical presentation is absolutely key. If you have a young male patient, typically in their 20s or 30s, experiencing severe lower back stiffness that lasts longer than 30 minutes every single morning, they are heavily flagged for this condition. We then look for the presence of the HLA-B27 antigen in their blood. Now, while many people have this antigen without actually having the disease, its presence alongside that excessive morning stiffness and decreased chest expansion is a massive diagnostic clue. That chest expansion issue happens because the joints connecting the ribs to the spine are physically fusing together. Okay, you've got to remember this classic medical memory hook. Can't see, can't pee, can't dance with me. It perfectly summarizes reactive arthritis, which was formerly known as Reader syndrome. It usually pops up following a bacterial infection, like chlamydia. The phrase perfectly maps out the symptoms for you. Can't see refers to conjunctivitis in the eyes, can't pee points to painful urination, and can't dance with me highlights the lever's heel pain caused by the arthropathy. It's a highly testable phrase for sure. And that brings us to our final category, Section 5, neuromuscular and blood disorders. Moving straight into how specific cellular targets dictate the disease. In hemolytic anemia, the body literally destroys its own red blood cells, which we detect using a Coombs test. Pernicious anemia is a fascinating one. Antibodies destroy the stomach's parietal cells, meaning you lose a crucial protein called intrinsic factor. Without intrinsic factor, you cannot absorb vitamin B12, and that leads to severe peripheral nerve demyelination. Then there's idiopathic thrombocytopenic purpura, or ITP. This condition drops your platelet count, causing pinpoint bleeding under the skin called petechiae. And finally, vasculitis causes the actual walls of your blood vessels to inflame and necrose, which means they die off. It's absolutely crucial to understand the stark structural difference here when autoimmune diseases cause physical weakness. Multiple sclerosis strips the protective myelin wrapping off nerves, specifically in the central nervous system. This leads to varied symptoms like double vision, also known as diplopia, and unsteady gait due to brain and spinal cord lesions. Conversely, polymyositis directly attacks and inflames the actual muscle fibers themselves, usually starting near the trunk of the body. When diagnosing polymyositis, a crucial step is ruling out statin medications because those common cholesterol drugs often cause muscle pain as a side effect. Now let's look at the mechanism behind myasthenia gravis. It is a devastating blockade right at the neuromuscular junction. Normally, a nerve releases a neurotransmitter called acetylcholine to tell a muscle to fire. But here, autoantibodies literally eat the receptors on the receiving dendrite, so the signal never connects. This presents with sudden stroke-like symptoms such as drooping eyelids and trouble chewing. We diagnose this using a tensilon test. This test temporarily stops the breakdown of acetylcholine, which floods the synapse and briefly restores the patient's muscle strength, clearly confirming the diagnosis. As we round out these specific diseases, we really cannot ignore incredibly severe specialized conditions like Goodpasture syndrome. In this life-threatening disease, antibodies specifically target the basement membrane of the glomeruli, which are the tiny, delicate filtering units inside the kidneys. This massive autoimmune attack simultaneously causes acute kidney failure and dangerous pulmonary hemorrhaging in the lungs. Managing this condition is no small feat. It requires immediate, high-level coordination between a nephrologist and a pulmonologist just to keep the patient stable. Across all these textbook conditions, you're going to see a unified medical philosophy. First, you have to definitively diagnose the misfiring cells in the lab using highly specific tests like the ANA or a Western blot. Second, you manage the local tissue symptoms, like using vitamin K for clotting disorders or NSAIDs for joint inflammation. And third, you attack the root cause by using heavy medications like corticosteroids or methotrexate. The goal there is to aggressively suppress the overall immune response and halt the cellular damage before it progresses further. As you review this extensive explainer for your exams, I want to leave you with this final, provocative thought. Modern medicine relies heavily on shutting down the immune system to save a patient's organs, but many of these conditions remain completely idiopathic, meaning their exact origin is still a total mystery. So ask yourself, what is the ultimate underlying trigger that causes the body to lose its self-recognition in the first place? And how close are we to finding a true cure that restores balance rather than just endlessly suppressing the entire system? Keep that in mind as you study. You've got this.